receive endocrine therapy or chemotherapy. Hormone positive breast cancers are trickier. We can tell our patients off the bat that if they're premenopausal, they're definitely going to be candidates for adjuvant endocrine therapy for 5 to 10 years. And, off the bat, their need or for chemotherapy depends on how advanced their cancer is, if their lymph nodes are involved or not. And those are the criteria we use. After surgery, if it's a localized node negative cancer, we do employ a test called an Oncotype DX score to figure out the role of chemotherapy in hormone positive breast cancers. And that's basically a test of 21 genes in which we figure out the recurrence rate, and patients are divided in high risk of recurrence to low risk of recurrence, and if they will benefit from chemotherapy or not, because the main benefit for these patients is adjuvant endocrine therapy. Next slide, please. And so I'll hand off the presentation to my partner, Dr. Novick, who's going to talk about the role of radiation oncology.
Thank you very much, Dr. Burki. Dr. Novick, are you there?
Yes.
You
Hi.
need to unmute yourself. Nice to meet you. It's all yours, and I will advance the slides for you if that's okay.
Absolutely. Thank you. I'll let you know when I need to go.
All right. Thank you.
I want to thank Dr. Burki for that very thorough and wonderful introduction to breast cancer care in the oncology world. I certainly do not feel that I can give the radiation aspect complete justice in 10 minutes, but I will certainly try to introduce the subject in a way that might help further future discussions, and I welcome questions at the end. So essentially, I like to start off with just talking a little bit about what radiation is, as most people come into the clinic not having had experience personally with radiation and perhaps having some fear and trepidation of radiation. Radiation is something that is used as a tool as part of that trimodality care model for breast cancer. I often compare its role to that of scrubbing dishes before putting them in the dishwasher. If you had a sink full of dirty dishes, you could potentially throw away some of those dishes, which may perhaps be the role of surgery. But if you start to scrub those dishes, that is the radiation, and then putting the dishes in the dishwasher afterward could be akin to chemotherapy or chemoprevention. So a lot of patients who come into clinic have had a wonderful surgery done by our surgeons. They may have also had chemotherapy or have at least met with medical oncology to talk about further preventative care that goes around the whole body to prevent anything the surgeon was unable, obviously, to remove should it linger behind. And the question often is, how do you know there's anything there? And the truth is that we don't. There's no imaging that we could do that would show us whether someone has breast tumor cells that are left behind after surgery, or perhaps in the vicinity of the area, but not part of the original surgery. And that's where radiation really comes in, because we do know that a significant proportion of patients after having had that surgery do recur. And what we try to do is use different factors to predict who those patients are, who most benefits from our treatment, and then also to try to decrease the potential toxicity and side effects of our treatment. So if you can go to the next slide, please. So I start off initially talking about the treatment of the whole breast with radiation. And this is perhaps the most common presentation in our clinic for breast cancer care. So this patient potentially would have had received a lumpectomy and would be a candidate for either whole breast radiation or partial breast radiation. I would say that the majority of patients are candidates for whole breast radiation, but in particular cases, they may be a candidate for what we call partial breast radiation. And the partial breast radiation has the advantage of allowing radiation to be delivered to a smaller proportion of breast and decreasing the amount of tissue that gets the radiation, and also potentially decreasing the total amount of time that someone needs to spend coming to our clinic for treatment. The whole breast radiation component traditionally was delivered in a 5 to 6 week schedule. We've found that most patients actually can qualify for a hypofractionation approach, which allows us to condense that same amount of radiation into a smaller period of time. And these patients actually seem to do quite well in terms of their side effects. In fact, I would argue that sometimes they do slightly better than the conventional fractionation, given that the skin typically turns over every 3 weeks, and by the time they're done with the hypofractionation, they are right at that point where the skin may potentially start to become irritated, but the radiation will have finished. The partial breast radiation is delivered in 2 different fashions. It's delivered either through a mammocyte approach, where coordination with surgery allows placement of a balloon into the lumpectomy cavity. And from there, we deliver radiation over the period of 10 to 30 minutes. And that is done usually over the course of 1 week in twice-a-day fashion. We've also been using external beam radiation, which is delivered by a machine that moves around the body without touching the body and delivers the radiation to that site, similar to how it would deliver to the whole breast, but to a smaller area. Next slide, please. And then the second major category of patients that come to our clinic are those that are candidates for post-mastectomy radiation. These patients often will have had nodal involvement, which makes them a candidate for radiation, but there are some patients who potentially might have other factors, such as their margin or the extent of the original tumor, that may make them a candidate for post-mastectomy radiation as well. Post-mastectomy radiation is delivered using conventional fractionation, which is what I discussed before, the 5 to 6 week scheduling of radiation treatment. There are some places that are using hypofractionation, certainly as a result of the experience during this pandemic. There's been increased interest in using hypofractionation for post-mastectomy radiation. The major trials have been completed outside of the U.S., and so there is some increased familiarity with hypofractionation. It's not something that we typically have used, particularly because the area that we're treating is so much larger by the necessity of treating the regional lymph nodes. But it is something that is potentially possible, and I anticipate that it will be something used more frequently in the future as we gain more experience and understand what doses are tolerable to different structures. Next slide. And when we're delivering radiation, as I mentioned before, one of our goals is to try to decrease the side effects. And one of the side effects that has come to light over the course of the past few decades is the side effect of adverse effects on the heart. I like to say that the old forms of radiation were unable and were without recognition of potential toxicity to the heart from radiation treatment. What they did find is that there was what they described a 25% increase of a cardiac event. However, many of these patients were at a 1% base increase or base risk of a cardiac event to begin with. So the absolute increase in risk of a cardiac event was from potentially 1% to 1.25%, but the relative risk was 25%, which was something that radiation oncologists recognized was not desirable for our patients. So over time, we've come up with more ways of protecting the heart during the radiation course, and I can say that we are, in most cases, able to decrease the dose to the heart to that which would have been for a left-sided tumor to that which would have been received if the patient had a right-sided tumor, and there's no absolute increase for right-sided tumors that are treated with radiation in terms of heart disease. So one of those techniques is using prone positioning. That's where the patient is laying on their front side, similar to how they receive the MRI biopsy, or how they receive an MRI or an MRI-guided biopsy. And that positioning allows the breast to fall away from the chest wall. Now, in some patients, that's not a tolerable position. In some patients, that also leads to the heart falling further into the radiation field, so that may not be the best treatment position for them. But there's also another one called deep inspiration breath hold that we use in our clinic that allows us to track the patient's breathing and have the patient take a deep breath in. And when the patient takes a deep breath in, that creates sort of a pad where the lung, which curves around the heart, expands and pushes the heart away from our radiation field. And we are very excited about this technology, and it's something that has been implemented here and used very successfully for many patients with left-sided tumors. The other option is potentially proton therapy. And I would say that most patients do not require proton therapy, but in certain cases where the dose to the heart is still high, despite our attempt at using these other techniques, proton therapy may be something that we utilize, since we do have our close connections with our colleagues downtown in their proton therapy unit. Next slide. And I again want to thank you very much for giving me the opportunity to present, and I look forward to your questions at the end.
Thank you, Kristina. I truly appreciate it. Right now, our next presenter, I'm going to pass over the slides, or will be forwarding them for her, is Dylane Wineland, who is our genetic counselor here at the Abrams Cancer Center here in Chester County. I welcome her, and as a reminder, if you have any questions or concerns during the presentation, please put them in the chat room. And then any information about our presenters tonight have been sent to you in your last email, and it gives you the information about all of our presenters as well as your contact. Dylane, thank you very much for your help tonight.
Of course, thanks, Susan, and thanks for the opportunity to present tonight. So tonight I'm going to be talking a little bit, a brief overview of what we know about hereditary breast cancer and how genetic testing can help prevent and reduce that cancer risk. Next slide.
We're having a little freeze here. There we go.
So here's just a brief overview. I'll start with the basics of genetics and hereditary cancer, talk about two of the major players, BRCA1 and 2. We'll talk a little bit about other genes we know of associated with hereditary breast cancer, and then how genetic testing can be useful. Next slide. So starting with the basics of genes and mutations. So we kind of think of a gene as like an instruction manual for your body. It's made up of a 4-letter alphabet that's called DNA. And depending on the job of the gene, so we all have 20,000 different genes in the body. Some of their jobs are to help our bodies fight off cancer. When someone's born with a mutation, which is kind of like a spelling mistake in how that gene is spelled, it makes the gene do its job less efficiently. So for the genes we'll be focusing on, we know of associated with cancer, those are their jobs in the bodies to help our bodies fight off cancer. So overall, if we think of all diagnoses of breast cancer, we know that only 5 to 10% are hereditary, so a small proportion of cancers, but it's still, an important factor to test for many times. Next slide. So if we think of the two genes that we know are most commonly found to cause hereditary breast cancer, meaning that we know of a mutation in that gene that is the cause of the cancer that is in someone or in the family. We know that BRCA1 and BRCA2, or sometimes called the BRCA genes, are the major players. So these two genes cause about 3% of all breast cancers. And when someone's born with a mutation in one of these two genes, it causes a syndrome called hereditary breast and ovarian cancer syndrome. And this syndrome significantly increases the lifetime risk for breast and ovarian cancer. Next slide. And we all share our DNA with our families. You get half of your genes from your mom and you get half of your genes from your dad. So when someone has or is born with a mutation in a gene, there's a 50% chance that when they have children, they will pass that same mutation on, which is why sometimes with hereditary cancer syndromes, we can see cancer that looks like it runs through a family. Next slide. So with a mutation in BRCA1 and 2, the general population lifetime risk for a woman to get breast cancer is about 12%. With one of these mutations, that risk does increase to a lifetime risk of about 60 to 80% by the age of 80 years old. So it's a significant increase from the average population. For the risk of ovarian cancer, general population is about 1 to 2%, so it's a much more rare type of cancer. With one of these mutations, that risk does go up to about a 40% chance. So again, significantly increased. Next slide. So besides breast and ovarian cancer, we know that having mutations in one of the BRCA genes does increase risk for other cancer types as well. There's an additional risk for a second primary breast cancer diagnosis after the first diagnosis that's increased, as well as a slight association with pancreatic and melanomas. Men can also get these mutations, so it's not just women. There's a 50%, so equal chance for both men and women to have these mutations. Their cancer risks are lower, but there is still an increased risk for prostate cancers, which we typically see at younger ages. They're more aggressive, as well as increased chance for a male breast cancer throughout their lifetime. Next slide. So where genetic testing comes into play, where it's useful, is if we know someone is born with one of these mutations that significantly increases the risk for certain types of cancers, what can we do about that? And really the goal with genetics is prevention, and to try to help either prevent or reduce the cancer risk as much as possible. Next slide. So for risk management, there are a few different options for people who carry these mutations. One is increased screening for those cancer types. Another is preventative surgeries. And lastly, there are different chemopreventive medications that are available. For women, the screening options for breast cancer, we start screening earlier and we like to screen more frequently. So starting that breast cancer screening at 25 years old, and then instead of just getting a yearly mammogram, they would screen with a mammogram, 6 months later get a breast MRI, 6 months later get a mammogram. So that more frequent screening to try to catch a cancer early at a much more curable, treatable stage if it pops up. For ovarian cancer, there are also screenings that would be implemented. Unfortunately, ovarian cancer is hard to screen for, so the screening options are more limited. There is also the possibility to have either preventative or risk reduction surgeries for women. So that goal is really to prevent that cancer risk from happening before it happens. For breast cancer, there is the option women have to do a bilateral mastectomy. So that's removing all of the breast tissue, which we do know does reduce the cancer risk by about 99%, as well as the option to have the ovaries preventatively removed. For men, again, there are cancer risks and some medical management guidelines that would change for people who carry these mutations. There are reproductive implications, so the ability to pass these mutations on to children. But for the men who carry them themselves, they would recommend doing breast self-exams and then a clinical breast exam every year at 35 years old. And then based on the amount of chest wall or breast tissue that's there, considering a mammogram, as well as earlier prostate cancer screening. So besides BRCA1 and 2, clinically today, we do know of other genes that are associated with hereditary breast cancer, and these genes can now clinically be tested for in what we call a multi-gene panel. So instead of looking at each gene separately, our genetic testing has the ability to look at multiple genes, all associated with breast cancer as well as other cancers, to look for those mutations. So this is where the genetic counselor in my department comes in. What genetic testing is it's typically either a blood draw or a saliva collection, and that test will read through a gene, kind of like a spell checker, and look for any mutations that someone may carry in the genes that we tell it to look for. The process of genetic counseling and testing, so there will be an initial consultation with a genetic counselor like myself. We'll review your personal and your family history, as well as some other factors to determine if testing is appropriate, as well as coordinating that genetic testing and disclosing and going over the results.
There you go.
So not every single person will qualify for genetic testing. There are certain guidelines and clues in a family or personal history that would make us more suspicious or warrant genetic testing. In general, the things that we look for that might warrant a genetic counseling or genetic testing appointment is cancer at a younger age. So for breast cancer, we're typically more concerned about premenopausal breast cancers, typically diagnosed before the age of 50 years old. We look for cancer that looks like it runs through a family, so in multiple generations of a family. We look for individuals who have had multiple cancers themselves, and then we look for those rare cancers like ovarian or pancreatic cancer that might indicate there's a hereditary cancer syndrome. We also look for male breast cancer, for example, sticks out. And then certain ethnic backgrounds or populations can also carry these mutations at higher frequencies than others. So if this sounds like something you're interested in or something that your family might qualify for, if you're local, you can reach out to the genetics department at the Abramson Cancer Center at Chester County to get more information or an appointment. If you're not local, there's a national website for genetic counselors, NSGC, and there they have a Find a Genetic Counselor tool where you can put in your address to find a genetic counselor who's local to you. And so thank you guys for your time and the opportunity to talk a little bit about genetics, and I'll be available at the end for questions if anyone has any.
Thank you, Dylane. I'm going to bring, or I've just brought down the slide presentation. Dr. Porter will be our next presenter who will be using the slide presentation. But at this time, I'd like to turn it over to Cynthia Brown. And Cindy is our nurse navigator, and she will be providing information on her role in not only the prevention or the team approach in preventing as well as surviving breast cancer. Cindy, thank you for coming on tonight. You're going to need to unmute yourself. Okay.
That's a good start. Thank you, Susan. So thank you everybody for coming out this evening. So as you know, I'm Cindy Brown. I'm the breast care nurse navigator at Chester County, and I've been here 13 years helping women that have been diagnosed. My role now starts that when a woman has a needle biopsy through radiology and they get a positive diagnosis, the radiologist informs the patient of that and then passes the baton on to me to become the woman or the man's person through their journey. So from the date of diagnosis, I am the person to help them through the continuum of care and help them with whatever needs that they have. And that entails a lot, because as a lot of us know, when you are diagnosed with a breast cancer, you don't feel sick. It's an emotional disease. So there's a lot that encompasses a breast cancer diagnosis. So some of the things that I help out with as a nurse navigator are emotional support. I listen to their concerns and their fears. I attempt to focus on the cancer patient, the caregiver, and the children, and everybody else who's involved. I pay close attention to the transition of fears depending upon where they are in their plan of care. There's fears that are associated with the date of diagnosis, their surgery, going into chemotherapy, or a diagnosis of metastatic disease. And I think that we need to focus our attention on where they are and address those needs as they come about. And that's part of my role. Another big thing that I do is resources. One of the things I like to say to our ladies and men is, I might not always have the answer, but I sure as well try to find out. And I try to use my resources within our healthcare system. I help out with financial resources, support groups, whether they're local or national resources. I help out with resources with surgical planning, physical therapy, nutrition, post-mastectomy care, anything and everything that they would need, whether they're going through surgery, systemic therapy, or radiation therapy. So I really try to utilize everything that I know to help the person get through each phase of care. Another huge thing, and I think that's where navigation really came from in the beginning, is expedition of care, bridging the gap. Time when you have a cancer diagnosis is very, very important. And so waiting and worrying I need to eliminate that. And that's a big part of my job. The longer the patient does not need to worry, and the quicker that we can unfold their unknowns, the better a patient's going to feel, and they're going to get more empowered and educated. And that's another part of my role. So from the date of the diagnosis to the surgical consult, to the diagnostic workup, to medical oncology, radiation oncology, end of life, all of that, we need to expedite through, because the quicker that they can get there and the more information they can gather, the better that they will feel and cope with their diagnosis. Education, as much as resources and support, educating the patient is huge. A lay person who gets a diagnosis of cancer doesn't really know that much about cancer. And then couple that with when they're at a consultation, how much are they really retaining? So I'm there to reinforce the information. I am there to just be a supportive person after their consults, to just go over it again, reflect on what was being talked about, and then help them to decipher the information. And again, empower them on making their decision, which is best for them and in their life. And patients call me, again, they have my cell phone, they call me through the continuum of care at whatever phase they're at. And then I think it's also important to not unload them on all the support programs all at once. We have to look at what phase of care they're at and give them the supportive programs they need during each phase, instead of just throwing it all at them at once. Another part of my job as a nurse navigator is being a mediator between the physicians and the patients and family themselves. I'm here to help the physicians expedite the patient's care too, so that when they show up to the doctor's office, they're well educated, they have all the stuff done that the doctors had asked for, and that their visits can go smoother. So that's a big thing. I do act as a bridge to a patient and a doctor. And I think really what it comes down to is that a patient who's scared with a cancer diagnosis does not get lost in their healthcare journey. I think that's key to my role. I work with the multidisciplinary team, and we really work as a group to make sure that men and women with the breast cancer diagnosis are very much taken care of. I just want to be, as a nurse navigator, a person that somebody can rely on through their journey, and that I can help them through whatever I can. So thank you for this opportunity. I think that's really encompasses my job, and I am so happy to be working at Chuck County Hospital. So thank you.
Thank you, Cindy. We appreciate your input as your role as navigating our patients through the system when they have a diagnosis of breast cancer. I know I've seen personally how you have worked with some patients that I've met in the community. So thank you again. And we do have a multi-valuable team that promotes or addresses this issue. Our next presenter is Brittany Fols, who is our social worker here at the Abrams Cancer Center at Chester County Hospital. We welcome her. And again, she will describe her role as a team approach in preventing and surviving breast cancer.
Thank you, Susan.
You're welcome.
So my name is Brittany, and like Susan said, I am the social worker here in the oncology department at Chester County. And I'm just going to spend a little bit of time talking about what my role looks like and some of the ways that I help to support patients and their families as they're going through the cancer continuum. So once a patient is connected to our cancer program, I may get involved in a variety of ways. Sometimes it's through self-referral from patients or family directly. It could be through detection of psychosocial distress that's identified through our distress screening process, which is a formal process that we implement at the Cancer Center, and also through potentially a patient's care team. So could be a nurse or a physician or nurse practitioner, anybody connected to the patient who thinks that it would be a benefit for the patient to connect with me. So my role in the Cancer Center is to help connect patients with support, resources, and information to help cope and manage any challenges that they may experience related to their breast cancer diagnosis. I think, Cindy said it really well, that, learning of a breast cancer diagnosis can bring up so many different emotions and concerns. And it's something that, I think really is vital that we address on top of the treatment course that we're looking at. So my focus when working with patients is on the emotional, social, financial, and spiritual concerns that a patient may have throughout the cancer continuum. And they can vary as a patient goes from diagnosis through treatment through survivorship. So I'm always a part in some way, or could be a part in their role of care. And so with that, I connect patients and families to support resources offered at Chester County Hospital, as well as in the community. One of the main ways that I do that is by identifying with the patient. I have a full assessment done with them, where we spend time addressing what specific concerns or needs that they may have. We spend time discussing available support resources and then refer them to services of interest to them. Just a couple of examples of some of the support resources that I do connect people with is counseling services, support programs. So that could be support groups offered within our cancer center as well as in the community, financial support resources, which is, as I'm finding more and more a big stress for many people, identifying assistance financially, both with household expenses as well as with concerns with treatment-related costs, navigating work and disability-related concerns, identifying resources to help at home if there's any difficulty with managing day-to-day care needs at home, transportation, so just to name a few. And oncology social work services are available to patients and families throughout all phases of the cancer continuum, from diagnosis through to survivorship. The most important thing that I just want to drive home is that support is available to you and to your family, and I'm very accessible. And I think Susan had shared my contact information as well, so I can be easily reached. I did just want to talk about a few specific programs that we offer here at Chester County Hospital. One of which we've had to do a lot of things virtually at this point. And one of the programs that we started through this virtual world that we're now in is a Living with Breast Cancer support group. It meets monthly. It is held over Blue Jeans, a virtual platform, and patients are able to participate at no cost. We've also developed a peer matching mentorship program where we're able to connect newly diagnosed active treatment patients with an individual with a breast cancer diagnosis that has gone through a similar treatment experience. And we found that has been a really important role that we've developed over the course of the year. We're also fortunate to have the Shine Foundation that provides many free programs and services to our breast cancer patients, including individual counseling support and free integrative services in the community, such as massage, facial, acupuncture, all that really focus on the whole person, the emotional and physical well-being of a patient. We also developed some lunch and learn educational programs. We have one coming up in November on holiday recipes that our dietitian will be providing. And then we also offer a virtual caregiver support group that meets monthly. And these are just some examples of the ways that we are here and available to support both patient and family as they're going through their cancer experience.
Thank you, Brittany. And actually, as a follow-up to this program tonight, we just developed a new promotional flyer for all of the support group services or support groups and services that Brittany has reviewed. So as a follow-up, I will be more than happy to send out to all of our participants tonight so they'll be aware of that service and support. Hi, Dr. Porter. How are you? I think you're unmuted.
Hi there.
Thank you for
how
joining
are you?
tonight.
Thank you for. Oh, thank you for inviting me. I'm happy to be here.
You know, you came in at the end of the program,
and we're running ahead of schedule.
And we are a little ahead, so that's an opportunity for more questions at the end. So just a reminder, if any of you have some questions, concerns, and comment, please make sure you put it in the chat room. We probably will open up the microphones because we're a little small group. But Dr. Porter, I'm going to share this screen, but I'm going to I'll actually forward your slides because we've been having some problems with our Zoom connection. So I'll bring it up and hopefully we'll be able to see it, and just bear with me. The modern means of communications always have a left curve. There we go.
All right. If we have any problems, I actually have my slides on my laptop and could share a screen if we need to.
Can you see the slides, everyone? Mm-hmm. Okay,
yes.
I think perfect. We're up. So there you go, Dr. Porter.
All right, thank you. So thank you so much for taking time out of your Thursday night to join us. I know these are very stressful times, and I appreciate everybody being interested and taking a little time to spend with us here. I am talking about breast cancer and some surgical considerations for breast cancer, and I've gone a little bit, it's a big topic, so I kind of covered everything broadly, but I'm happy to take whatever questions come up through this. So I kind of did a little bit, I was looking through the program, I didn't really see any as much about screening. And I apologize, I was on a different Zoom call for the Committee of Cancer for the beginning of this, but I kind of had this Zoom up to see what was being discussed. And I don't think that we have really talked about screening, but I wanted to touch on it just a little bit because it's gotten confusing over the past few years. If we go to the next slide, there are several recommendations that have come out, whereas it used to be very uniform. The American Cancer Society, for instance, recommends starting mammograms maybe from 40 to 44, but certainly no later than 45. They recommend annually from 45 to 54, and then every 2 years over the age of 55, although you can continue annually. They recommend stopping when life expectancy is less than 10 years, which is my least favorite recommendation because nobody knows when our life expectancy is going to stop. The American College of Radiology, they are a little more aggressive, annually beginning at age 40, stop with a life expectancy less than 5 to 7 years. Next slide. The American College of OB-GYN offers screening beginning at 40 at least, but you must start no later than 50. And then mammogram every 1 to 2 years, so very similar. And they recommend screening till at least age 75. The American Society of Breast Surgeons, my society says discuss screening starting at 40 to 44, and then annually from 45 to 55, and then annual or every 2 years after 55. So if you hit the slide one more time, Susan. Thank you. Just a summary from my takeaway from that is, I really think consider starting at 40, especially for increased risk, family history, and other dense breasts, and then certainly annual exam from 45 to 75, maybe every 2 years after 75. And for me, I always have a conversation with my women about when to stop. And really, for me as a surgeon, I think we should stop screening when my patient would not want to do something about it anymore. In other words, if surgery is not an option anymore, then we should probably stop looking for small things. But if my patient is in good health and willing to go through surgery, I'd rather find things when they're smaller than when they're bigger. And that's my 2 bits over that. Next slide. Which brings us right into surgery. Surgical considerations of breast cancer. And I kind of took a little bit of a historic review to this. Back before 1960, 1970, the mastectomies of our parents or grandparents, was something called a radical mastectomy. It was a radical Halsted mastectomy. And I had a picture here. I took it out because I thought maybe it'd be upsetting, but it's really a very disfiguring surgery. It removes the breast, obviously, but also the pectoralis muscles so that you can see the rib cage right over the skin right over the rib cage. And sometimes, depending on whether those muscles between the ribs were very developed, you could see the heart beating through, you know, or the movement of the heart and the chest. Many lymph nodes were removed, level 1 through 3. Level 3 lymph nodes go up into the neck. There were very high rates of lymphedema associated with that. So in the 1970s, we started doing less. This began our journey of do less in breast surgery. Studies showed, or data showed, that leaving the pectoralis muscle was sufficient, did not affect survival. We also removed less lymph nodes. We kept the lymph nodes in the above the shoulder, and there was really the same effectiveness. Next slide. And I'm sorry. And one more thing about the radical mastectomy is we started. We still do the radical mastectomy when we must remove lymph nodes, but since radical mastectomy, we've developed lesser versions of mastectomy in that we can leave some skin or all of the skin, meaning the nipple as well. So we've gone through more and more conservation of the breast with no detriment to survival or safety of women. And from there, we move to the, and in some situations when it must happen, lumpectomy or otherwise known as partial mastectomy. And in those studies that were done, these are older studies in the 1980s, proved that women live just as long. There's equal survival for lumpectomy with mastectomy. So one of the things that I will frequently hear is, and I get it, it's intuitively it makes sense to say, I want to live, just take my whole breast. But the reality of it is that taking the whole breast is not the most important thing in treating breast cancer. Taking the cancer out is the most important thing in treating breast cancer. So removing extra healthy breast tissue does not make women live longer. However, when they studied those, when they followed those women out that had a lumpectomy as opposed to a mastectomy, although they lived just as long, the recurrence rates were higher in the just lumpectomy group. So that group was then combined with radiation, as Dr. Novick talked about, and the recurrence rates were similar to mastectomy. So lumpectomy with radiation is as viable a surgical consideration as mastectomy for the average risk woman. And ideally, you know, 70% or more of early stage breast cancer can be treated with lumpectomy and radiation. I included a picture here. This is what a lumpectomy can entail. It can be something as small as, you know, a tiny scar. Ideally, this was just a stock photo. I just kind of put it in there, but ideally I would put the incision a little bit lower even to blend into that areola. So you really, hopefully, will one day have a time where you're not worried about looking at your breast and reminded of your breast cancer. Next slide. So how do we do a lumpectomy? I mean, it's easy when you can feel it. When you can feel it, it's easy to get out. When we can't feel it, so in other words, if you have a mammogram, there's something that was found that is, you know, not able to be felt or less than a centimeter, really only seen on mammogram or ultrasound, the radiologist will place a clip at the time of biopsy, and then my challenge becomes how to get that clip out. So this picture here is an example of a wire localization, and that's what happens before surgery. Immediately before surgery, the patient will go to the radiology department in the hospital, and they will numb the skin and place a wire next to that clip. And then I can make an incision and follow the wire into the breast and take that tissue out. And it works. It's you know, it's very low tech. It works just fine. It's time consuming in the hospital. It makes the morning longer, and it's also, you know, it's a little bit less sophisticated to have a wire kind of hanging out of your breast. It's covered, and you don't travel through the hospital very far, but there's a better way to do it, I think. If you look at the next slide. What we have now available at Chester County is a Savvy Scout, which is wireless localization. So in the picture in the lower left-hand corner, there's what looks like a little lightning bolt, and it's called a reflector. It's a little antenna. It sends these little signals off from the breast. It's placed in radiology. It used to be up to a month before surgery, but really it has essentially, you know, years of ability to be placed ahead of time. So after this is determined to be cancer or something that needs to be removed, the radiologist you can return to the radiology department, where this can be placed similar to the biopsy. They'll numb the skin and deposit this next to the clip. And then in the operating room on the day of surgery, I activate it with this wand that you see there. And the reflector sends off these signals like honing beacons. So I can make an incision in a more cosmetically appropriate place in the breast, not just where the wire is going in, and follow that signal into the breast and take out the tissue. Either way, whether it comes out with the wire or with the Savvy Scout, whatever comes out, we x-ray it in the operating room while the patient's asleep to make sure that we have both the biopsy clip and either the wire or the Savvy Scout. And then I take additional margins all the way around, because nationally speaking, about 20% of the time, there can be microscopic disease present at the margins of a lumpectomy. And we don't want to leave, we don't want to leave any cancer there. We would like to ideally to take everything out with a healthy rim of tissue around the cancer. So after that part of the surgery, then the incision is closed and the patient can go home from a lumpectomy. So we've really gone far in terms of being able to minimize the morbidity or the impact associated with breast cancer surgery. Next slide. Next slide. So back, oh, I'm sorry, one back. Thank you, Susan. Oh, there we go. So really, I just told you that there's essentially no difference in effectiveness between lumpectomy and mastectomy, lumpectomy with radiation and mastectomy. So what it really comes down to is the decision for mastectomy really comes down to two things, in my opinion. One is anatomy. Are there more than one areas of concern in the breast, or is this close to the nipple? Is this something that I'm just not going to be able to save the breast? Am I going to have to take too much breast tissue out and it would be disfiguring? All of these indications are very reasonable indications for mastectomy. The other one, Dylane very eloquently talked about, and that's the risk of future cancers. So obviously known genetic mutations would affect our ability to save the breast. We would have to have a long conversation if my patient was predisposed to developing breast cancer again, we'd have to talk about how we would continue screening, or would it be better to remove the breast kind of in a risk reduction measure. In addition, even without a known genetic mutation, if my patients were to meet Dylane and have genetic testing and everything comes back negative, it's still a reasonable thing to do to opt for bilateral mastectomies if there is a strong family history of breast cancer, because we're making the assumption with genetic testing that we know all the mutations there are to know, but we don't always. So strong family history in and of itself does increase your risk for future breast cancer. Similarly, high-risk lesions found in the breast tissue, these would be things like atypia and a type of tissue called lobular carcinoma. OSW-C, which is a horrible name. It's not cancer, but it has a risk of developing cancer in the breast. It's an evidence that the breast knows how to make mistakes. And so those atypical cells themselves do not turn into breast cancer, but they are associated with the risk of future breast cancer in either breast. So that would also be a reasonable reason to opt for mastectomy. Next slide. So just to kind of clear up some myths, right? Mastectomy for the average population really doesn't decrease recurrence rates. It also, and this is a little bit controversial, but again, for the average population, it doesn't decrease your development of new cancers, meaning that, and this is a little bit counterintuitive in a sense, but obviously you could say, Dr. Porter, if you're removing breast tissue, how can you not have new cancers? There's always a little bit of breast tissue left behind with mastectomy, but I think the point of that statement is that the risk of a second cancer for a low-risk tumor in the average population is really very small and not enough to really warrant just routine mastectomy. Next slide. Just talking about risk, but Dylane, again, I just wanted to go through this quickly because I know Dylane talked a lot about them. But when I first sit with patients and meet them, there are several different tools that we can look at to calculate breast cancer risk in the future. And the most reliable one is really the thought to be the Tyrer-Cuzick breast tool. So I will sit down, it takes factors. I will sit down with patients and go through their family histories with cancers, history of atypia, when they had their first period, when they had their first deliveries, or if there were no deliveries, height, weight, breast density, ancestry. There are certain ancestral lineages that are more associated with mutations, and also a history of chest wall radiation. Next slide. Oh, that was just a little animation, sorry. Dylane went through these already, so we can just kind of go through, I'll just leave this up there just to say that these are some of the things when we talk about surgical decision makings that I take into consideration when I meet a patient for the first time. Next slide. Oh, and then it's gonna, I think, again, more indications for genetic screening. And another slide, please. Okay, so reconstruction. If you've done a mastectomy, what can we do for reconstruction? So the first thing to say is that the standard of care really is to meet the plastic surgeon before surgery and have reconstruction done, or at least the initial part of the reconstruction done at the time of mastectomy. So there's really the two most common forms of reconstruction are implant-based reconstruction and tissue-based reconstruction. And I've listed them in these two columns to kind of compare and contrast. In implant reconstruction, the reconstructed breast is made, of an implant, usually silicone. It could be saline. Silicone is determined to be absolutely safe in terms of, years ago there was concerns over leakage of silicone implants causing systemic disease. The silicone implants today are generally they're engineered to not be able to leak even if they are ruptured. They're more of like a gel or a viscous consistency. I will mention very briefly that there is a type of lymphoma that recently in the past 5 years or so has been associated with implants. It's a specific type of implant called a textured implant that we do not use here. Our plastic surgeons generally do not use them. And the incidence of the implant-associated lymphoma is exceedingly rare. So the benefit of implant-based reconstruction, initially it's a faster surgery. The plastic surgeon puts the expander in immediately after reconstruction, but it does require stepwise procedures for reconstruction. the reconstruction will, the expander will initially be inflated, and then ultimately after the inflation, which could be, 4 to 6 to 8 weeks later, you return to the operating room for the implant exchange. Alternatively, the tissue transplant, the tissue-based reconstruction is tissue that's actually transplanted from elsewhere on your body. So often the most common site is the abdomen, where they take the abdominal fat associated with the blood vessel and reconnect the blood vessel into the chest wall. So it's a much longer surgery initially, on the order of 8 to 12 hours initially. So they're really reserved for women who are very healthy, minimal health problems in terms of not having cardiac risk factors or diabetes or hypertension. The blood vessels are really relying on them to maintain their health after they're reconnected. This surgery does also require revisions over the short term, but they're usually very small surgeries, and it's really more in terms of contouring the tissue that was transplanted up there. And it has the benefit of not having implants. So I just put that up there for a quick summary. Obviously, I'm not a plastic surgeon, but do work closely with our plastic surgeons, and this tends to be what I see. Next slide. Oh, and that's it. So somehow I've used up all of our time where we got ahead. But thank you for allowing me to speak.
At this time, as we said earlier, we'd like to open it up to some questions as our question and answer segment. I will ask all of our presenters maybe to unmute themselves, and the glasses had to go on so I can read some of the questions. So bear with me. You might be seeing them as I read them. We have a question that is stated as following: what is the role of grandparents' genetic mutations to breast cancer or other cancers? What about other family members who have other cancers, such as pancreatic cancer?
Yeah, I think I can help answer that, and others can jump in if they have other, input as well. So, we do share our DNA with our grandparents. You share 25% of your DNA with any one of your grandparents. So if there is a known mutation that's linked to a hereditary cancer syndrome in a grandparent, that is something that you could also carry or be at risk for, and something that would warrant some genetic testing. Typically, we'd want to start in a stepwise to test other family members when there's a known mutation in the family. So testing that grandparent, and then testing, the parent above them, and then testing you, so we can kind of rule out who in the family would be at risk. We know mutations don't skip generations through a family, so your parent would have to carry that mutation for then you to have a chance to also have inherited it. But it's a good question, and I think regarding other types of cancers, pancreatic cancer is one we know that can be due to hereditary cancer syndromes. It has been linked to the BRCA or the BRCA genes. So that's one of those red flags in a family where if we see it anywhere in a family, if we see anyone diagnosed with a pancreatic cancer, it does warrant some genetic testing. We think it's worth evaluation. In general, certain types of cancers are more likely to be hereditary. Breast cancer, ovarian cancer, pancreatic cancer, colon cancer, especially at younger ages, are ones that typically stick out more than other cancer types.
Any other comments or suggestions from our other presenters? Unless not, I'll move on to the next question. Here is one on a timely issue. How has COVID changed the world of breast cancer in prevention, also in particular for treatment in general? Any thoughts or comments as we all face this, as it started out in mid-March and currently we're still addressing it as we move into the fall months?
So yeah. I think initially in March is when we got the brunt of the hit, and there were a few management changes that would not, and the way we changed treatment was to make sure it would not overall impact the prognosis or anything of our patients' breast cancers. Like some people who could wait for surgery and could be started on neoadjuvant treatment with endocrine therapy with small hormone positive breast cancers, we went ahead and did that. And by now, all of our patients have had their surgeries. So in March, when everything came as a surprise and things were unexpected, we did change our treatments, but people who needed chemo, they got chemo. We all worked as normal as possible. And, I don't think any patients had bad outcomes because of any delays that happened.
I agree. I also, it's notable that the people who needed surgery also had surgery. The patients who had their chemotherapy before surgery for various reasons that were diagnosed in the winter, if their time to go to surgery was that time, then they went to surgery. We followed the guidance of our national societies. There were several consensus statements that were made through the Committee on Cancer, American Society of Breast Surgeons, ASTRO. It was a remarkable time in that many of these societies got together and they looked at hospital resources, because remember, initially, the delay of care that was initially done, or I should say the reordering of care that was initially done, was in an effort to preserve hospital beds, because we didn't know what was going to happen in terms of need for ventilators and need for ICU. And there were plans being put into place for contingencies and making the operating rooms ICU beds. Fortunately, that didn't happen. Chester County did a great job of flattening the curve. And now we really have largely resumed all of our cancer care. The second thing that happened is that screening did take a big delay, and it's early data, but probably the delay of screening was probably a bad thing, and is probably not something that we will ever do again. It was being done nationally, and everybody was following the guidelines of our national societies, but we are worried about how this will affect our breast cancer numbers, colon cancer numbers years down the road. So now our efforts are really to very wholeheartedly encourage everyone to resume their usual preventative health care. Get your mammograms, get your colonoscopies, have your blood work done, go to the doctors, go to the hospitals. We're working hard to make it safe. So that's really our biggest message for that.
Thank you, Dr. Porter, that's perfect. Actually, Dr. Porter, that you had touched on, this might be another question to you. The question here is, or the statement, I am intrigued by something called the Seve Scott, which you did go on, or explained initially that it is available here in Chester County. Is it true? And how has this technology that you've seen changed a woman's experience? I know you touched on it a little bit.
Yeah, I think overall it's a more humane way of doing lumpectomies on these small lesions that we previously had to kind of coordinate schedules, and it would make the day much longer on the hospital day. Sometimes women would have to have their wires placed at 7:30 or 8 o'clock in the morning, and their surgery would be hours later after the numbing medicine started to wear off, and sometimes it was painful. Most of the time it's pretty well tolerated, and we still do wires in certain situations. But I think overall the bringing the Savvy Scout on board for lumpectomies has really just benefited women for sure.
One other question, actually I received privately, and one of the questions, and I think maybe Brittany or maybe the other presenters can answer this: does Chester County Hospital participate in any clinical trials here for breast cancer prevention or as well as treatment? I would assume is the direction, or any thoughts?
Yes, we do have numerous clinical trials for prevention, for survivorship, for genetics. We share a lot of trials with the downtown folks, but we have independent trials here as well. So it's, every time our patients are presented in the multidisciplinary tumor boards, we also evaluate if there's a trial that they would be candidates for. And our research nurses are actually really good in identifying patients for trials.
And is there a number, anybody in particular they need to get a hold of that I maybe can follow up with the participants tonight to provide that information?
Yes, so Nona, who's our clinical trial research person, she's our go-to person to ask for trials.
Okay, I will follow that up to see after this evening's program, along with the information about what support groups we have here at Chester County, and that will probably be sent out tomorrow afternoon at the earliest. One other question here is, when starting to take tamoxifen, how long before any side effects can will be started?
Tamoxifen?
I think it's tamoxifen,
yes.
yes.
Yeah, so every individual is different. Some people do well for a few months and then start having side effects. Some people start having side effects within a few weeks. Mostly people don't really have too many side effects. The more common side effects are hot flashes, and some people complain of a few more just feeling achy in general, especially in the morning. But it's not like everybody has side effects to either the tamoxifen or in postmenopausal women and premenopausal women now, the aromatase inhibitors. What I counsel my patients before they start is that we always have options to switching to other agents or medications once if they are having side effects with one, because a lot of times they don't have side effects with the other medication we prescribe, and a lot of patients don't have side effects. So people are apprehensive before starting, but it's and we try to help them with their side effects before we change the medication, or switching oftentimes does help. And if side effects are too much for our patients to tolerate, there's always an option to stop as well at some point.
I see one other question. In addition to the potential effects of radiation on the heart, are there any other organs that can be affected by radiation to the breast?
So radiation typically affects the organs that are within the path of the beam. I would say that the other organ that we're paying a lot of attention to is the lungs. And this is particularly important for smokers. For non-smokers, the effect on the lungs typically is either temporary or very rare. So for my patients who are smokers, I certainly counsel them about smoking cessation and the importance of smoking cessation. But should they continue smoking, then certainly we do a lot of the same things we do to conserve the heart. We also try to conserve the lungs, and deep inspiration breath hold can be one of those techniques, or prone positioning as well. For patients that are getting radiation to the lymph nodes, there is an area of lymph node that's right next to the neck. And as a result of that, sometimes the esophagus gets some dose, and patients can sometimes feel the sensation of a pill getting stuck in their esophagus. But that typically is seen as a temporary problem. And typically patients just watch their diet, try to avoid things that might be hard or might catch within the esophagus, and try to eat softer foods. And that typically works in getting them through their treatment.
I don't see any other questions in the chat room, but if the presenters are okay with this, if any of our participants would like to open their mics up and ask a question, the last few minutes of our presentation, we will let that arrangement go through to give you that opportunity. Your mic is, or your logo is on the left side of your screen. If I'm reading this correctly, you can unmute it. If you would like, there's no pressure to do so. But also at this time, while we're waiting to see if there's any other questions, concerns through the chat room or through an open mic, we do have a quick survey at the end of the program that before we close the program, I will put that up and ask you to answer 2 questions that are there. But any comments or suggestions or for future programs, if you could put them in the chat room, that would be wonderful. Are there any other additional questions? You can be shy too.
Hi, My name is Cindy Easton. Can you hear me?
We can.
Okay, I don't have a question, but I just wanted to thank all the presenters. I thoroughly enjoyed this, and the level of expertise on this team is just through the roof. I was diagnosed with cancer back in 2016. Catherine Porter was my surgeon. Cindy Brown was my nurse navigator. And I love them both very, very much. Because of the team, I'm here today enjoying my retirement. And I'm just so grateful for their expertise and their guidance. And I just think the world of them and would recommend them to friends and relatives. Thank you so much.
Thank
you, Cindy.
Love you, Cindy.
Thank you. See you in November.
There's that reminder there, but that's probably the best question or comment we can hear as we come to the end of our program. I know I can echo that because I became the stalker of this program. It's one part of my job I don't like is organizing and coming after people saying, please help me out here. But this team came to my call when we asked it and tried to celebrate Breast Cancer Awareness Month. So I myself would like to thank all the presenters tonight for their time and their energy, but most importantly, their expertise. We have a wonderful team here at Chester County. I have the luxury to be in the preventive part, but I go out in the community and I hear stories just like what Cindy says. So I thank you. I did put up a poll if you could take some time before you leave. And again, we're also looking for your suggestions for future programs. We cannot serve our community without your input. So again, any other thoughts or comments from our presenters before we close out?
Thank you.
Thank you, everybody, for joining us tonight.
But thank you. We appreciate you coming virtually. We hope in the near future we'll be going back in person to some of our wellness prevention and programs, but we'd like to end it all. We are still in tough times. Please remember to be safe as we all address this as a community for COVID. And we will get through this at this point, so just be patient. So tonight, everybody, thank you for coming, be safe, and we hope to see you soon. And again, everybody on the CCH team, thank you so much for your help. I appreciate it. Be safe now. Good night.
Thanks,
Good night.
Thank you, guys.
Thanks, guys.
Thank you.
I'll write a personal note in a few days. I owe you big time. Thank you.
Stop it.
I know where to find you. Bye, ladies. Bye.
Bye.
Thank you. Be
All
safe
right,
now.
get out of here.
Thank you, Dr. Burki. Glad to meet you.
Oh,
Good
goodness.
to meet you too.
All right, Cindy, I see your little one behind you or no, but
I know, I'm just trying to get off. I'm like, how do I get off this thing?
maybe you did. All right, be safe, everybody. Thank you. Good night.
Tell Larry I said hi. Oh my gosh, so much. All right, leave.